Understanding Medicine.
Professor Aziz Rehman here. I am presenting another video on clinical medicine, and this is the fifth in the series. We are covering the theoretical part, and I'm just presenting the outline, and the actual demonstration of clinical method will be covered in separate set of videos, which is very soon going to follow. Now, if patient has respiratory symptoms, then of course you would examine the respiratory system after doing general physical examination. But if patient has got some non-respiratory symptom, even then a respiratory system has to be examined in its turn. And this is going to give you an outline of examination of respiratory system. And of course, depending upon patient, there would be more emphasis on certain points, and there will be just basic introduction in other areas. Now, I think you might have examined hands, and you might have inspected patient face in general physical examination, but if you have not done that, I believe that examination of a respiratory system should also start with examination of hands and also face. Now, in hands, you may look for two important things. One is cyanosis, the other is clubbing. Of course, any other thing which is abnormal, you have to make a note of it, but specifically look for cyanosis and clubbing. Now, if you have cyanosis, then you would like to know if the cyanosis is present only in hands or is it present on the lips and tongue also. Why do we want to know that? Because if cyanosis is present everywhere, including peripheries, it would be called central cyanosis. Now, that would refer to a central etiology. The etiology would be related to heart or lungs. So central cyanosis actually refers to the etiology. In central cyanosis, basically unoxygenated blood on the right side gets mixed with the oxygenated blood on the left side, and the blood which goes to the body from the heart, wherever it goes, is not fully oxygenated. So that would result in cyanosis, which would be everywhere. Now, if you are doing endoscopy, bronchoscopy, colonoscopy, you will see cyanosis on the mucosal surfaces also. That is what is central cyanosis. So if you examine hands and there is cyanosis, you must confirm if cyanosis is present on the lips or the tongue. If that is the case, then it is central cyanosis. If cyanosis is present only on the extremities, and especially if extremities are also cold, they're not warm, then it would refer to a peripheral cause. Now, peripheral cause is usually due to a shock-like condition or peripheral vasoconstriction or low cardiac output. That would be obvious from the general condition of the patient. Patient's vitals would be disturbed, but you can differentiate central cyanosis from peripheral cyanosis with this fact, the distribution. Central cyanosis is everywhere and peripheral cyanosis is present only in the peripheries. And the second difference is that in peripheral cyanosis, the extremities are likely to be cold, whereas in central cyanosis, extremities are likely to be warm as the rest of the body, maybe even slightly warmer. Why? Because in all those conditions where there is central cyanosis, there is actually hypoxia, and hypoxia is a vasodilator. That means more blood is coming to the peripheries and more heat is also, more warmth is coming to the peripheries. So hands may be little warm or at least not cold. So this is how to differentiate. And I think briefly, what is cyanosis? Cyanosis is bluish discoloration of the skin and mucosae due to high contents of unoxygenated hemoglobin. How high? 5 grams. In most patients, you need 4 to 5 grams of unoxygenated hemoglobin to produce this bluish tinge. irrespective of total hemoglobin. It is not the percentage, it is absolute amount of 5 grams. So if you are polycythemic patient, then you are more likely to have cyanosis even if you do not have other issues. And if you are anemic, you are less likely to have cyanosis even if there is poor oxygenation. So I think this is clear, and final judgment may be done if you have a case of if you have a case of cyanosis and you are unable to differentiate between centered and peripheral cyanosis, you may want to do arterial blood gases. In central cyanosis, oxygen level would be low because there is poor oxygenation. Either there is mixing of right-sided blood with the left-sided blood due to a shunt, or there is a lung problem, there is not proper oxygenation. In either case, oxygen level will be low. Whereas in peripheral cyanosis, in the main arteries, in the brachial artery or radial artery or femoral artery, where we normally take blood for arterial blood gas, the oxygen tension should be normal. Partial pressure of oxygen should be normal, because only in the peripheral capillaries, in the small capillaries, because of the sluggish flow, there is greater extraction of oxygen into the tissues, and that is why there is cyanosis. So I think arterial blood gas can differentiate between central cyanosis and peripheral cyanosis. In central cyanosis, oxygen level will be low, whereas in peripheral cyanosis, there would be normal. Remember, there may be a clinical condition where you have a mix of peripheral as well as central cyanosis. Also remember, there could be a central condition that causes peripheral cyanosis, like severe heart failure, cardiogenic shock can cause peripheral cyanosis. When we are talking about the central cyanosis, there are two main groups: either right to left shunt, like in Fallot's tetralogy, or there could be a lung disease. One way to differentiate between the two is to give 100% oxygen, and if there is no improvement at all after say 15 minutes of oxygen therapy, you repeat arterial blood gases and there is no improvement, that is likely to be a shunt, because in shunt, blood never goes to the lungs. A significant portion of blood never goes to the lung and never gets oxygenated. So even if you give 100% oxygen, that would not make any difference. Whereas if the disease is in the lungs, whatever lung disease, giving 100% oxygen, there should be some improvement in cyanosis. So that is how we differentiate. Then we examine hands for any clubbing. Clubbing, of course, could be due to pulmonary disease, could be due to cardiac disease, could be due to liver disease or intestinal disease. But there are some important lung conditions where there may be clubbing. One such condition is lung cancer, or bronchiectasis, or pulmonary fibrosis, or lung abscess, or empyema. These are all important pulmonary conditions where there could be clubbing. And I think you already know clubbing has got various stages. Initially, there may be just the obliteration of the angle. Normally, there is an angle between nail and the nail bed, but that angle becomes less and less obvious, and then it becomes straight. Then there may be clubbing, and there may be fluffiness, and then there may be actual the thickening of the distal part of the radius and the ulna also. So that's stage 4 clubbing. I think detailed discussion on clubbing will be covered in separate video. So before you examine lungs formally, I think you just need to examine hands of the patient and have a close look on the face, see if there is any cyanosis or clubbing. The respiratory system is examined under these 4 headings: inspection, palpation, percussion, and auscultation. I think these are basic techniques of clinical examination, and all 4 are applicable to respiratory system. In fact, if I have to identify one system where you can learn all 4 methods of examination, it is the respiratory system. In inspection, of course, you have a close examination and just see if there is any abnormality, And with palpation, you touch the body and see if that abnormality is real, and you look for further signs. Percussion is a very, very important uh, science, and I'm going to explain to you the physics behind it, and then auscultation with the help of stethoscope. Now let's first take up inspection. Now in inspection, you basically, I think, have a closer look on the entire chest and also the related system, the upper respiratory tract, and also I think you look at the way patient is breathing, and there should be good light. First of all, if you have not examined for cyanosis earlier, you do it now. You examine the lips and the ear lobules and the tongue and the mucosal surfaces in good daylight. If there is cyanosis, you make a note of it, and you also try to differentiate between peripheral or central cyanosis. Now, if patient has other symptoms and signs of respiratory disease, then cyanosis is likely to be central. Expose the chest and notice any abnormality. For that, you need to learn the normal shape of the chest. Now, if you examine multiple healthy people, you would know what is the normal shape of the chest. Normally, the AP diameter is almost 2/3 of the lateral diameter. Now, whatever type of your body physique may be, you may be tall, you may be stout, but normally AP diameter is less than the lateral diameter. And normally the sternum is flat, there is no abnormality. So if there is any, like sternum is depressed, or there is pigeon shaped chest, or there are any deformities, or chest is very, very abnormal like barrel shaped chest, you make a note of that. And similarly, you also examine the breathing pattern, which I think actually you start doing that even before interviewing the patient. If patient is breathing comfortably, then you are assured that there is no serious respiratory problem. Now, if patient is having problem with breathing, patient is having labored breathing, patient is having a specific pattern of breathing, there are several patterns of breathing. If patient has any of those, you make a note of that. For example, if patient is taking deep inspiration, that would suggest something. If patient takes a brief inspiration and makes a very, very long expiration and has to exert to make it possible, that would also mean something. So I think you make a note of breathing pattern, whether breathing is rapid and deep or rapid and shallow or whatever, is it regular or whatever. So I think there's breathing, the one pattern of breathing is called chain stroke breathing. The patient is very, very unwell and there is brain damage, there may be chain stroke breathing. Any deformities like pectus excavatum or pigeon shaped chest or barrel shaped chest, or just any deformity, kyphosis, kyphoscoliosis or scoliosis, any deformity. Now, what is the importance of these deformities? There are two important, I think there are two importances. One is that the deformity will suggest some disease. I think that is number one. The second one is whatever deformity, it is going to interfere with the breathing. So normal shape of the chest is mechanically best for breathing. Any deformity is likely to affect breathing and is likely to cause a sort of restrictive lung disease. So I think any abnormality you have to make a note of. Then accessory muscles and intercostal spaces. You know, normally we breathe very, very quietly and effortlessly. Normally inspiration is active, and how does inspiration occur? Our brain sends signals through the phrenic nerves and through the intercostal nerves to all the muscles, intercostal muscles and the diaphragm, to contract, and that would expand the chest. And because of expansion of the chest, the pressure within the chest cage will reduce and that will suck air inside. So that is the mechanism of inspiration. And inspiration is an active phenomenon, whereas expiration is usually a passive phenomenon. Once inspiration is over, there is no more contraction of muscles. So due to elastic recoil of the intercostal muscle, ribs and other structures, the chest goes back and the air is pushed out. So normally inspiration is active, expiration is passive. Inspiration is longer, expiration is relatively shorter. And normally we do not use our accessory muscles. But if patient is having breathing difficulty, patient has got some obstructive airway disease or has got some restrictive airway disease or has got any reason to have breathing difficulty, patient would be using accessory muscle. Now what are these accessory muscles? These sternocleidomastoid muscle, pectoral muscles. So these muscles will be prominent and you will see the patient is actually taking help of these accessory muscles to make breathing possible because the work of breathing has increased. And patient may be adopting a specific posture like tripod position. Patient makes this posture and fix the arms on the chair arms or the bed so that he can use the accessory muscle for the expansion of the chest. So I think an experienced physician would know just by looking at the patient and just by the fact that accessory muscles are active, and you would know that patient is having some respiratory difficulty, either obstructive or restrictive airway disease. In fact, it is actually possible. It is actually possible to tell if it is restrictive or obstructive just by looking at the patient's chest and the way patient is breathing. You just need to develop experience for that. So after inspection, then you do palpation. I think whatever you inspect, it is a natural tendency that you then touch that thing and confirm your findings. So that would be applicable on examination of chest also. Now, first of all, I think you examine trachea. That would be included in inspection also. If trachea is deviated, you will note in the inspection, but formally it is tested in palpation. So there are different methods. You just make sure the trachea is in the sternum, in the center. The trachea passes here, and we have equivalent space on both sides. Medial end of the clavicle on both sides and the trachea, the distance between them is the same. So you insert your finger here on one side and then the other side, and then make sure that both are equal. So if both are equal, trachea is in its normal position. Trachea may be slightly, very slightly deviated to the right, even in a normal healthy person. But if trachea is significantly shifted to one side, then you will say that trachea is deviated, and that would suggest two groups of disorders. Trachea may be either pulled by a disease on the same side. Suppose there is a disease on the right side and that might pull the trachea to the right side. Or there may be push of trachea to the opposite side. Suppose there is a disease here that might push the trachea to the opposite side. And what are the diseases which can pull the trachea? Those diseases where there is loss of volume. If there is collapse of lung or if there is fibrosis, there would be net loss of volume. Since in the chest there cannot be vacuum, that would pull trachea toward the disease side. Now, if there is another condition which takes up volume, like there is pleural effusion, there is pneumothorax, there is a big tumor or empyema, that might push the trachea to the opposite side. So based on the tracheal position and presence of other physical finding, you can differentiate between tracheal push or tracheal pull and reach a definitive diagnosis. But as a first step, you have to make sure that the trachea is in normal position or deviated. So whenever trachea is deviated, immediately you would also, I think, want to make sure if apex beat is in its normal position or not, because there are conditions where both apex beat and trachea both are deviated. So this would represent the upper part of the mediastinum and this would represent the lower part of the mediastinum. So on those diseases, there could be push or pull of both. Then you check chest expansion. With the help of measuring tape, you would measure the chest expansion. So in a normal healthy person, it should be from 3 to 5 inches in full expansion. You could check expansion when patient is breathing quietly, and you can also check expansion when patient is asked to take a full inspiration and expiration. If chest expansion is reduced, that would indicate some disease of lungs or chest cage. Then differential chest expansion. It is possible that one side of the chest is not moving as well as the other one. So if there is a disease on one side, whatever the disease may be, the affected side actually moves less. So there is a method which I will demonstrate later. You can compare one-sided expansion with the other one, and the side which moves less is the disease side, and the side which moves more is actually the normal side. Then use whatever deformities you had noticed in inspection, that you make sure that they are present by touching them also. Any abnormal pulsation, abnormal veins, deformities, anything, I think. And then you also look at the back, and the spine should normally be curved like this. If spine is straightened or there's kyphosis, scoliosis, that should be noted. Now is the percussion. Percussion is very important because I think it has got a very interesting physics behind. And what is the physics? When you strike some body organ, it produces a sound. And that sound is dependent on the nature of the structure underneath. Now, for example, if you strike your thigh, that would produce a tone that is called dull. Now, if you percuss over a big gas bubble in the stomach, the kind of sound you hear is what is called tympanic. But in the lungs we have, most of the lung structure is air, but it is divided into trillions of small alveoli. So that produces a typical sound that is called vesicular breaths, that is called resonant percussion. So when we percuss on the lungs, we expect normal resonant tone. If it is not, if the tone is not resonant, then we suspect some disease. Now it could be hyper resonant or it could be dull. So depending upon these findings, we will make a diagnosis. Now please note down that it is usually not possible to make any final diagnosis on the basis of one single finding. So whenever we examine any system, including respiratory tract, we have to actually examine the whole system, and then we add up all those physical findings, and then we come up with a diagnosis. So percuss both sides. In lungs, we have to compare one side with the other side. Percuss both sides from apex to base, and from the front, from the back, and on the sides. So you percuss intercostal space to intercostal. So compare one side with the other one, and assuming both sides are normal, then you can rule out several diseases. But you should make sure that on the left side, when you percussing from the front, on the left side there is a heart. That would obviously change the percussion tone here. And on the right side, the base, there is liver, so that might also change the percussion note. Otherwise, there should be same tone on both sides. And you detect areas of dullness or areas of hyperresonance. You need actually a lot of experience to be able to pick up these findings, but they are very useful. Now, just to give you some example, if there is pleural effusion, that means in that part there is no air, and that will produce a dull percussion note. Now, if there is a pneumothorax, instead of having air in the lung, it is free air. That would create a hyper-resonant or tympanic tone. So this is how we differentiate. Position of diaphragm can be checked with when we percuss from apex to base. We expect a resonant tone, and at the level of diaphragm, suddenly the percussion tone, the note change, and then that indicates the position of diaphragm. We can actually check the mobility of diaphragm also by doing percussion during inspiration and expiration. So that completes percussion, and now let's talk about auscultation, which is of course most important, because most of the physical finding in cardiovascular system as well as in respiratory system comes from auscultation. The auscultation is the technique of listening to the lung sound with the help of stethoscope. So first of all, you need to learn the proper use of your stethoscope. When we examine chest, we mostly use diaphragm. But make sure, if patient is very sweaty, or patient has got very hairy chest, or if you examine through clothes and patient is wearing some silky clothes underneath, particularly women, then that may produce some abnormal sound, and an experienced person will be able to tell that these are not real findings. But if you're not that experienced, you might be actually misled. So it is best to examine the exposed chest, and if patient has got very wet chest, it is good to dry it, wipe it with a tissue paper. And if patient has got very hairy chest, it is best to examine the chest with the bell, because diaphragm is likely to give you wrong finding in this case. Again, auscultate both sides from apex to base and pick up any areas of abnormal breath sounds. Now, abnormality may be related to the intensity of breath sound. There may be breath sounds which are less loud, or there may be some abnormal breath sounds. So whatever the case may be, you have to make a note of that. Then you have to differentiate between two normal types of breath sound. Normally, when we auscultate on the lungs, the type of breath sound we hear are vesicular. What is meant by vesicular? There is no way I can explain, because there is no way you can describe the actual voice of a barking dog. You have to hear to know what is it like. So you have to examine multiple healthy people to be able to find out what is meant by vesicular breath sound. And normally we also have bronchial breath sounds on trachea. So there are two types of sounds. On the lungs you have vesicular breath sounds, but on the trachea you have bronchial breath sound. Sometimes these bronchial pattern may be seen in the lungs also. That would indicate some problem. Then you look for additional sounds, adventitious sounds, which are not present in a normal healthy person. And there are three main types: rhonchi, which are continuous sounds; crepitations, which are interrupted sound; or rubs. There may be a combination, and for a beginner it may not be easy actually to differentiate one from the other, but as you gain more and more experience, then you will be able to differentiate between them. And it is actually important to differentiate, because differential diagnosis of rhonchi is different than crepitation, and that of crepitation is different than the rub. So I think we need to learn the technique, and we have to develop the skill to be able to differentiate between the three. And there could be a case where there are multiple types of adventitious sounds. Now let me explain what are the differences between vesicular and bronchial breath sounds, and then we'll talk about rhonchi, crepitation, or rubs. Now let me describe the differences between vesicular breath sounds and bronchial breath sounds. Vesicular breath sounds are produced by flow of air into and out of alveoli, which is a normal phenomenon. That means normal breath sounds are vesicular and they are rustling in character, and this is how we describe their character. You need to actually examine number of patients to have this impression what is meant by rustling in character. And then there is no pause between inspiration and expiration, because the moment inspiration ends the expiration starts, so there is continuous kind of sound during inspiration as well and then expiration. You can of course tell there is an impression of to and fro. The air is going in this direction, then going to the other direction, that you can tell, but there is no pause between inspiration and expiration. And inspiration is longer than expiration in a normal healthy person. Now, when we compare it with the bronchial breath sounds are produced by flow of air in the main airways. One good example is trachea. So if you want to make an impression of how would the bronchial breath sound would sound, you can auscultate on the trachea. Now that breath sound is normal on the trachea, but if you hear the same character of breath sound anywhere on the chest, that would be abnormal. So that might indicate some problem. And they are described as hollow or tubular in character. Again, as I said, you will have to have the impression by having practical experience. And there is distinct pause between inspiration and expiration, because this bronchial sounds are produced by flow of air in the main, and further down there are small air spaces. So when air is passing through the small air spaces, that would represent pause between bronchial breath sounds. So you can tell that these are bronchial breath sounds if there is a clearly appreciable pause between inspiration and expiration. And when we have bronchial breath sound, the expiration becomes longer. Sometimes it is as long as inspiration, or I think it can be even longer. Here we have already mentioned that inspiration is longer, but in bronchial breath sounds, there may be the expiration may become longer or may be equal to inspiration. Now both these breath sounds are actually normal. That means in a normal healthy person, you have these breath sounds. Vesicular breath sounds are heard on all the lungs, whereas bronchial breath sounds are heard only on the trachea, and if they're heard on the rest of the chest, that would indicate an abnormality. Now let's move on and we talk about some abnormal sounds which are not present in a healthy person, but they may be present in some people with respiratory disease. And these sounds are called adventitious. Adventitious is something additional, something which is not normal, and they may be present, and there are three types: rhonchi, crepitation, and pleura. I think you must learn the skill of differentiating between the three, because the differential diagnosis of respiratory disease would base purely on these findings. Now, I think after examining the patient, based on what adventitious sound this patient has, I might be able to give a confident diagnosis of, say, bronchial asthma or left ventricular failure or pneumonia. So it is very, very important. Now let's talk about them to learn what they are. First of all, rhonchi. Rhonchi are continuous and whistling sounds, like they are heard throughout inspiration or throughout expiration or biphasic. So continuous whistling sound. Patient typically describe them as wheezing or whistling. Then they may be sibilant or sonorous. Sibilant bronchi are high-pitched bronchi, and they are mostly seen in asthma, whereas sonorous bronchi are relatively low-pitched sounds, and they are more characteristic of bronchitis. This is a feature of asthma, and these are usually seen in COPD, two groups of disorders where there is obstructive airway disease. Then these may be reversible or fixed. There may be a person who at one time have lot of bronchi, and when you have a follow-up examination, there may not be any bronchi. That means these bronchi were reversible. That would indicate reversible airway disease as seen in asthma. Or they may be fixed or only partially reversible. Somebody having COPD, chronic obstructive pulmonary disease, there may be bronchi present always. They may reduce or may vary in intensity, but they're always present. Then they may be localized or generalized. For example, bronchi may be present in typically COPD patient and asthma patient. Bronchi are generalized. That means they are present everywhere, although they may be heard better at certain points as compared to other points. Best part to examine for bronchi is on the back, I think just below the scapulae, because that is where you have maximum lung volume. So if bronchi are present in a localized area, there may be some problem there like mucus plug or foreign body or a tumor, but mostly they are generalized. So I think based on the presence of bronchi, their character, if they are sibilant or sonorous, if they are localized or generalized, and if they are fixed or variable, and you can make a reasonably accurate diagnosis of a respiratory disorder if you know this skill. Now, then we talk about the crepitation. This is another type of adventitious sounds. These are interrupted or crackling sounds. Interrupted or crackling sounds like purring of cat and or like breaking bubbles. If you roll your hair like this, the kind of sound you hear is the like crepitation. But you need to actually examine people with crepitation to have a good impression what is meant by crepitation. Then crepitation may be fine or coarse. You can tell from their character whether they're fine or coarse, but I think traditionally those crepitations which are heard only during inspiration and sometime toward the end of inspiration only, they are classified as fine. But those crepitations which are present everywhere, they are called coarse. So there may be fine or coarse, or they may be inspiratory or fine, and inspiratory as well expiratory biphasic, they are coarse. Why do we want to know if they're in fine or coarse? Because we can build up the differential diagnosis. For example, if somebody have bilateral basal fine crepitation, that would indicate heart failure. Localized fine crepitation may be a sign of pneumonia. Bilateral basal coarse crepitation may be indicative of fibrosis. Generalized coarse crepitation may be indications of bronchiectasis or some other advanced lung disease like COVID pneumonia. And then you have to see if the crepitations are present only in certain area, like apical crepitation may be indicative of tuberculosis. Bilateral basal crepitation may be indicative of fibrosis or heart failure. Generalized crepitation may be seen in pulmonary fibrosis or emphysema or bronchitis. So I think very important physical finding. So now let's move to the third adventitious sound, that is pleural rub. Pleural rub is produced by the rubbing of two layers of pleura against each other. In a normal person, in a normal healthy person, when we breathe, both surfaces of pleura, they rub against each other, but there is no sound because normally pleura is very smooth, covered by pleural fluid, and there is no sound. But if pleura is roughened, inflamed, thickened, that might produce a sound, and that might be that is called pleura. But I think beware of some imitators. If somebody is wearing silky clothes and you're examining through the clothes, you might get something which is just like a rub. And somebody has wet chest, somebody has got hairy chest, you could have a sound which is just like a rub. So I think it is best to examine the chest when exposed and wipe it with the tissue. Typically associated with the pleuritic pain, because pleural rub is seen in pleuritis or pneumonia, and the sound comes when we breathe, when the pleural surfaces rub against each other. That would also produce a pain which is pleuritic pain. Pleuritic pain is the pain which varies with breathing and coughing and sneezing. So I think if somebody has pleuritic pain and you hear auscultate the patient, and the sound is very likely to be a pleural rub. There is a characteristic, there is a very typical character of pleural rub. There is superficial and leathery, biphasic to and fro character. You, I think, clearly feel as if something is rubbing against another thing, and that is a sign of pleural rub. Pleural versus pericardial. Now, depending upon where are you auscultating, if you are auscultating on the back, on the lung, then of course the sound you are hearing is pleural. But if you are auscultating here, then similar sound may come from the rubbing of pericardial surfaces. But of course, this would be at the respiratory rate like 15, 16 per minute, and this would be at the pericardial, at the cardiac rate like 60, 70, 80 per minute. But in some cases, it may be difficult. And to make the matter more complicated, there may be pleuropericardial rub also. So I think you need some experience to differentiate between the three. Then they would indicate pleuritis, either pleuritis just as one condition in its own right, there's inflammation of pleura, or it could indicate an underlying lung disease like pneumonia, like pulmonary embolism, pulmonary infarction. So I think these are some of the conditions which would come in the differential diagnosis. So hopefully, after examining the hands and the lips and then trachea and the chest, going through these stages of inspection, palpation, percussion, and finally auscultation in a good light and in an unhurried way, you should be able to come up with multiple physical findings, and then taking all the physical findings together, you should be able to make a diagnosis. If you are experienced, I think in most cases suffering from lung diseases, you should be able to come up with a clear-cut diagnosis, COPD or pneumonia or tuberculosis. But of course, in many cases, you would require some tests to confirm. And let's very briefly in one slide go through those tests. So you like to see the X-ray chest. X-ray chest is almost done as a routine whenever somebody has a respiratory symptom. Unless patient had an X-ray chest recently, then you might not repeat. Otherwise, I think all patients with respiratory diseases need an X-ray chest, because X-ray chest will confirm your findings, confirm your diagnosis, and might give additional clues to the diagnosis. Now, even if you are an experienced physician or internist, it is very likely, and you are very particular, very careful in examination, it is possible that X-ray gives you some additional information, or it gives you some information which is contrary to what you had thought on examination, because physical examination has got some limitation. Then in some cases, pulmonary function test would be done, and in some cases, arterial blood gases will be done, and pulse oximetry has become a routine test that might also give you some information. So all these with history and physical finding will give you a definite diagnosis. So that is about a respiratory system. I hope you like this lecture, and I hope I was able to give you some insight into the principle of examination of respiratory system, the actual demonstration of these methods will soon follow. Please stay tuned. This has been Professor Aziz Rehman from Medurstand-Understanding Medicine.